Imagine a searing electrical shock that starts at the base of your skull and fires up the back of your head. For millions of people, this visceral, shooting pain is a daily reality. Physicians trace this agony to specific neurological triggers. The most prominent is occipital neuralgia, inflammation or injury to the nerves in the upper neck. It often coexists with chronic migraines or posterior circulation strokes, which can lead to severe complications like cortical blindness. Chronic pain of this intensity eventually overwhelms the nervous system. The constant anticipation of the next attack rewires the brain's stress response, leading to a state of permanent physiological alert. This diagram illustrates the direct link between physical body and mind. Patients with chronic neurological pain frequently develop severe depression, anxiety, and PTSD. It creates a closed feedback loop. Physical pain triggers psychiatric distress, which tightens muscles, increasing the frequency of future attacks. The standard medical response often overlooks this connection. Doctors frequently prescribe a generalized painkiller to numb the physical symptom, leaving the underlying psychological damage unaddressed. Physical and mental health are tightly linked. Successfully treating severe head pain requires a dual rehabilitation roadmap that repairs the physical nerve pathway and the psychological state simultaneously. Clinical diagnosis begins at the anatomical root of the problem, the Greater Occipital Nerve, or GON. This diagram shows the nerve's path. The GON emerges from the C2 spinal nerve, piercing the trapezius muscle. The blue rings identify compression sites. Notice the dense yellow web below, the Crouvillier plexus. Here, cervical nerves communicate directly with the brain's pain-processing hub. When muscle tissue constricts the greater occipital nerve at these specific sites, it sends a relentless flood of distress signals into the brain's emotional centers. Identifying this structural pathway is the first step in care. A physician must determine the exact site of the physical bottleneck to disrupt the patient's pain loop. The Dr. Gangadhar Physiotherapy and Pain Management Clinic, or DGPC, addresses this through foundational care. They implement targeted craniocervical exercises and posture corrections to physically decompress the neck muscles. Because the cycle involves the mind, physical therapy is paired with mental health support. Trained counselors work with the patient to build psychological resilience while the body begins to heal. However, reaching an accurate diagnosis is difficult. Occipital neuralgia, cervicogenic headaches, and migraines share nearly identical symptoms, a reality known as phenotypic overlap. This similarity often leads to patients receiving the wrong treatment for years. To resolve this confusion, specialists use a greater occipital nerve block. This injection identifies the physical source of the pain while simultaneously offering the patient immediate relief. This schematic demonstrates the procedure. A physician injects a local anesthetic exactly 2 centimeters lateral and 2 centimeters inferior to the external occipital protuberance, the bony bump on the back of the skull. If the anesthetic stops the nerve from firing and the headache vanishes, the source of the pain is confirmed. Combining empathy-driven physical therapy with precise nerve blocks provides a clear path forward, preventing the use of ineffective long-term medications. For refractory cases, where the pain persists despite foundational treatments, clinical care must escalate. The next step involves chemical interventions, like botulinum toxin A, or Botox. These injections act anti-nociceptively, meaning they inhibit the release of specific proteins that carry pain signals to the nerve endings. If chemicals fail, specialists employ pulsed radiofrequency, or PRF. PRF is a technique that uses short bursts of electrical energy to modify a nerve's pain transmission without causing permanent damage to its microstructure. For the most severe, intractable pain, surgeons utilize occipital nerve stimulation, or ONS. ONS is the surgical use of electrical pulses to interrupt chronic pain signals before they reach the brain. This diagram shows the ONS setup. A surgeon places thin lead wires beneath the skin at the base of the skull. These connect to a power source in the upper chest called an internal pulse generator, or IPG. The IPG delivers constant, pain-canceling electrical impulses directly to the nerve. These advanced tools offer highly targeted, customizable relief. They manage even the most resistant pain while protecting the body's physical integrity by avoiding irreversible nerve destruction. Surgically silencing a nerve stops the biological trigger. However, long-term recovery depends on addressing the deep neurological and psychological impact left in the wake of chronic suffering. The DGPC philosophy operates on the principle that recovery is not a one-time fix. It is a continuous process of building skills and maintaining specialized empathetic care. To permanently break the pain-depression cycle, advanced medical treatments must be anchored by ongoing psychological counseling. This allows patients to process the trauma of long-term illness. Finally, integrating fitness planning and physical rehabilitation restores a patient's daily function. Rebuilding physical strength is what ultimately allows individuals to return to their jobs and their families. Debilitating conditions like occipital neuralgia do not have to be a life sentence. By treating the whole patient, the physical wiring and the mind alike, individuals are empowered to reclaim their lives and achieve lasting wellness.